Hello everyone, today I'm going to share with you one of the articles that I have come across the Cochrane database, which is entitled Beta Blockers in Patients Without Heart Failure After Myocardial Infarction. This is a systematic review with meta-analyses, and I credit this recording to the authors of this work, who are listed here. They are Safi, Sethi, Korang, Nielsen, Feinberg, Gluud, and Jakobsen. Their work could be found in Cochrane Database of Systematic Reviews 2021, Issue 11, Article number CD 012565, with the URL listed in this slide. The background of their work. Cardiovascular disease is the #1 cause of death globally. According to the World Health Organization, or WHO, 7.4 million people died from ischemic heart disease in 2012, constituting 15% of all deaths. Beta blockers are recommended and are often used in patients with heart failure after acute myocardial infarction. However, it is currently unclear whether beta blockers should be used in patients without heart failure after acute myocardial infarction. Previous meta-analyses on this topic have shown conflicting results. No previous systematic review using Cochrane methods has assessed the effects of beta blockers in patients without heart failure after acute myocardial infarction. Objective. The authors use systematic review and meta-analyses to assess the benefits and harms of beta blockers compared with placebo or no treatment in patients without heart failure and with left ventricular ejection fraction greater than 40% in the non-acute phase after myocardial infarction. The authors performed an exhaustive methodological search using the databases listed in the slide, and they have considered the articles from their inception to February 2021. Types of studies. The authors included all randomized clinical trials, irrespective of publication type, reported outcomes, publication status, publication date, and language. The authors excluded cluster randomized trials due to the inferiority of these trials compared to individually randomized clinical trials. The authors did not specifically search for non-randomized studies. Types of participants. The authors included any participants, irrespective of their age, whom trialist describes as receiving a diagnosis of myocardial infarction in the non-acute and stable phase after acute myocardial infarction. The authors excluded trials assessing effects of beta blockers among patients with post-myocardial infarction heart failure, defined as clinically overt heart failure with New York Heart Association Class 3 and 4, and left ventricular ejection fraction less than 40% at the time of discharge from the hospital. However, they have included participants with KILIP Class 1 and 2 and New York Heart Association Class 1 and 2 heart failure, and with acute heart failure as defined by the trialist during hospitalization with acute myocardial infarction. Types of interventions. The authors included 3 types of trials, which include beta blocker compared with placebo, beta blocker added to a co-intervention compared with a similar co-intervention, and beta blocker compared with no treatment. They accepted any co-intervention which are any medical therapy or any revascularization strategy, provided it was planned to be delivered similarly to experimental and control groups. They assumed that no interaction between effects of co-interventions would even out in both groups, so possible effects of beta blockers would be reflected in the results. Any type of beta blocker as the experimental intervention, selected beta blockers, and beta blockers that are combined alpha and non-selective beta blockers. They included trials assessing effects of any type of secondary prevention beta blockers commenced in the non-acute phase after myocardial infarction. They used trialist definition of whether beta blockers were administered in an acute or subacute phase or in a non-acute phase, and included only trials in which beta blockers were administered in the non-acute phase following acute myocardial infarction. However, as a rule of thumb, they considered beta blockers administered more than 7 days after myocardial infarction as administered in a non-acute phase. They included trials in which beta blockers were administered within 7 days after myocardial infarction if trialists described participants as fully recovered after acute myocardial infarction, assuming beta blockers were then administered in the non-acute phase. They assessed these trials in a post-hoc subgroup analysis, comparing trials in which beta blockers were administered more than 7 days after myocardial infarction to trials in which beta blockers were administered within 7 days after myocardial infarction. Study flow. From the exhaustive literature or evidence search, the authors have come up and gathered a total of 19,145 records, and with the use of exclusion and inclusion criteria they have set, they were able to use a meaningful 56 publications, including reports on 25 trials that had 5 trials which were going on at the time of their publication. Data collection and analysis. Authors follow their published protocol, with a few changes made and methodological recommendations provided by Cochrane and Jakobsen and colleagues. 2 review authors independently extracted data. Their primary outcomes were all-cause mortality, serious adverse events, and major cardiovascular events, composite of cardiovascular mortality and non-fatal myocardial infarction. Their secondary outcomes were quality of life, angina, cardiovascular mortality, and myocardial infarction during follow-up. They assessed all outcomes at maximum follow-up and systematically assessed risks of bias using 7 bias domains, and they assessed the certainty of evidence using the grade approach. Main results included 25 trials randomizing a total of 22,423 participants with mean age of 56.9 years. All trials and outcomes were at high risk of bias. In all, 24 of 25 trials included a mixed group of participants with ST elevation myocardial infarction and non-ST myocardial infarction, and no trials provided separate results for each type of infarction. 1 trial included participants with only ST elevation myocardial infarction. All trials except 1 included participants younger than 75 years of age. Methods used to exclude heart failure were various and were likely insufficient. A total of 21 trials used placebo, and 4 trials used no intervention as the comparator. All patients received usual care. 24 or 25 trials were from the pre-reperfusion era, published from 1974 to 1991, and only 1 trial was from reperfusion era, which is published in 2018. The certainty of evidence was moderate to low for all outcomes. Their meta-analysis showed that beta blockers compared with placebo or no intervention probably reduced the risks of all-cause mortality and myocardial infarction. Both of these meta-analyses yielded to moderate certainty evidence. They have also conducted another meta-analysis showing that beta blockers compared with placebo or no intervention may reduce the risk of major cardiovascular events and cardiovascular mortality. This set of outcomes yielded to low certainty evidence. Thus, their evidence seems to suggest that beta blockers versus placebo or no treatment may result in a minimum reduction of 10% in risk ratio for risks of all-cause mortality, major cardiovascular events, cardiovascular mortality, and myocardial infarction. However, beta blockers compared with placebo or no intervention may not affect the risk of angina. No trials provided data on serious adverse events, according to good clinical practice from the International Committee for Harmonization of Technical Requirements for Pharmaceutical for Human Use, nor on quality of life. Conclusions from the authors. Beta blockers probably reduce the risks of all-cause mortality and myocardial infarction in patients younger than 75 years of age without heart failure following acute myocardial infarction. Beta blockers may further reduce the risk of major cardiovascular events and cardiovascular mortality compared with placebo or no intervention in patients younger than 75 years of age without heart failure following acute myocardial infarction. These effects could, however, be driven by patients with unrecognized heart failure. The effects of beta blockers on serious adverse events, angina, and quality of life are unclear due to the sparse data or no data at all. All trials and outcomes were at high risk of bias, and incomplete outcome data bias alone could account for the effect seen when major cardiovascular events, angina, and myocardial infarction are assessed. The evidence in their review is of moderate to low certainty, and the true result may depart substantially from the results presented. Future trials should particularly focus on patients 75 years of age and older and an assessment of serious adverse events according to ICH, GCP, and quality of life. Newer randomized clinical trials at low risk of bias and at low risk of random errors are needed if the benefits and harms of beta blockers in contemporary patients without heart failure following acute myocardial infarction are to be assessed properly. Such trials ought to be designed according to the Spirit statement and reported according to the Consort statement. Here are the supporting documents that the authors provided in their published work. Here is the summary of evidence at maximum, summary of findings at maximum follow-up with the outcomes listed on the left. Outcomes include all-cause mortality at maximum follow-up, major cardiovascular risk events, serious adverse events, quality of life, and angina. The columns that follow include illustrative comparative risk with assumed and corresponding risk, relative effect, number of participants, certainty of evidence according to the grade approach. This is a continuation of the slide prior with the outcomes, cardiovascular mortality, and myocardial infarction. This figure shows the risk of bias, wherein it summarizes the author's judgment about each risk of bias item represented as percentages across all included studies. The bias domains they have considered include random sequence generation, allocation concealment, blinding of participants and personnel, blinding of outcome assessment, incomplete outcome data, selective reporting, and others. Here is the forest plot of comparison with the outcome all-cause mortality at maximum follow-up. Here is the forest plot of comparison for the outcome major adverse cardiovascular events at maximum follow-up. Here is the forest plot for the angina pectoris as their outcome. Displayed here is the forest plot of comparison with cardiovascular mortality as the outcome. Lastly, here is the forest plot of comparison for our last outcome, which is myocardial infarction at maximum follow-up. Thank you, and again, I credit this recording to the authors of the published work.